Yes, and so yeah, I was asked to talk about necrotizing enterocolitis, and rather than talk about various forms of treatment of necrotizing enterocolitis, I'd like to talk a little bit more about the problem itself and where we've been, where we are now, and where we're going in the future. And mainly, I want to talk about the future, but let's start a little bit with some, let's see if I can move this forward. The agenda is I'm going to talk a little bit about a historical perspective, then discuss current concepts of pathophysiology, especially in relation to the intestinal microbial environment, then talk about current concepts on prevention of intestinal injury, problems with our current approaches based on lack of a definition and the fact that NEC is not a distinct disease, and how to address this lack of a definition, and then the future. I'm going to start with giving you a quiz. And I don't want you to necessarily answer these questions verbally, but just think about them as I move forward here. So question number one, please define necrotizing enterocolitis. Number two, is necrotizing enterocolitis a distinct disease? Number three, do babies with Bell's stage 1 or 2 NEC have intestinal necrosis? Do we have a clear understanding of the pathophysiology of NEC? Do we have clear, accurate, clinically relevant biomarkers for NEC? And are there clearly effective preventative strategies? And last, should we start over again and redefine intestinal injuries and feeding dysfunctions that we are calling NEC? And I want to put NEC into quotes here. So let's go back in history. Here we have the cover of a book written by Dr. Alexander Schaefer in 1965. And the title of this book is Diseases of the Newborn. How much was there written about necrotizing enterocolitis in this textbook? Nothing. No mention was made at all of necrotizing enterocolitis in 1965. 6 years later, in 1971, in this textbook, Schaefer and Avery, also called Diseases of the Newborn, there were a few sentences about necrotizing enterocolitis. So what has been going on over these last several years, and why has necrotizing enterocolitis become such a prevalent and important problem? Well, one of the things is that we are saving babies that look like this. You can see this little 24, 25-week gestation premature is on mechanical ventilation, and this is certainly a mode of therapy that has saved many, many lives over these last 50 to 60 years in neonatal intensive care. But oftentimes what happens to these babies is this. You see this baby with a very distended, shiny appearing abdomen. This baby ended up going to surgery, and the entire bowel was dead. And the baby ended up dying of septic shock, hypotension. Nothing could be done to save this baby. So what we've had now is a history of over 50 years where we have this problem called necrotizing enterocolitis, and we really have not made much progress. Why? Well, here's one reason. We lump several diseases under the umbrella diagnosis of NEC. And these are imposters. I call them imposters because we put them into the same data set. These get put into the various data sets that we use for research. And these data sets end up being garbage. They are not very useful because we do not have a good definition of necrotizing enterocolitis. There are animal models that we use very commonly that do not represent the disease that we see in human preterms. And there's also a narrow focus on individual pathophysiologic pathways rather than systems. So in other words, the researchers that have been looking at necrotizing enterocolitis are very frequently focused on something like the toll-like receptor 4 pathway or hypoxia ischemia. And this narrow focus is usually not by itself the pathophysiology of what we call necrotizing enterocolitis. Here's a paper that was published in Pediatric Research just a couple of years ago. And the title of this paper is Defining Necrotizing Enterocolitis, Current Difficulties and Future Opportunities. And in this paper, they talk about 8 different definitions of necrotizing enterocolitis. What does this mean? If you have 8 different definitions, that means you don't have a good definition. And this is really important because defining a disease or a condition has important implications. Because if we cannot have a specific diagnosis as a specific disease entity, then how can we possibly study this in terms of pathophysiology? So here are some of what I call the imposters of NEC. And one of them is stage 1, 2, and 3. When Dr. Bell in Kansas, he's a pediatric surgeon, developed the stage 1, 2, and 3 criteria, he was never thinking about defining a disease entity. He was talking about staging severity of intestinal disease. And in 1979, when Dr. Bell developed these, we were taking care of babies that were very different than the kind of babies that we see today. So the kind of babies that we see today, if you look at most of those babies that are born less than 27 weeks gestation, and you use what Dr. Bell used as a stage 1 criteria, almost all of those babies would have stage 1 necrotizing enterocolitis. Stage 2 usually relies on radiographic and medical criteria. Well, very commonly, the radiologist will read an abdominal x-ray and say, this looks suspicious because there is this bubbly appearance in the right upper quadrant. Does that mean that this baby has necrotic intestine? Usually not. What that means is that there may be some signs of something going on. And very often, this is a misreading because some of these babies may actually just have stool in that region of intestine. And this is mistakenly read as pneumatosis intestinalis. And when we get that report from the radiologists, what do? We are afraid that if we don't treat that baby, that that baby may turn out to have much more severe disease. But very often, treatment is worse than the preventative strategies that we use. So for example, if we treat these babies with 7 days of NPO, 7 days of antibiotics, putting down a tube, that could be very harmful because the baby is not going to grow very well during that period of time. You actually cause damage to the gastrointestinal tract by not putting in food, and you can damage the microbiome of these babies. We have some babies that have cardiogenic ischemia, and this cardiogenic ischemia derives from problems such as hypoplastic left ventricle, interrupted aortic arch, and sometimes even a significant ductus arteriosus can cause some problems with the blood flow to the gastrointestinal tract. And that cardiogenic ischemia is not the same disease or same process that we see in our premature babies. Then we have these other problems, variants of food protein-induced enterocolitis, spontaneous intestinal perforations. These are highly problematic because they can mimic what we are calling necrotizing enterocolitis. Babies who have spontaneous intestinal perforations very often do not have their intestine looked at by the surgeons. the surgeons will place a drain into the peritoneal cavity, and these babies do not get recorded as having spontaneous intestinal perforation. They get recorded as having necrotizing enterocolitis. So these are some of the problems that we have with this diagnosis. Now, what about the pathophysiology? Many, many studies have been done to try to evaluate the pathophysiology of necrotizing enterocolitis. And I'm going to talk about some of this pathophysiology in some of these studies, but I want to start with a little disclaimer. At this part of the presentation about pathophysiology, we'll discuss our current understanding, and that this hopefully will be refined within the next couple of years, because our current understanding of pathophysiology is highly lacking. So here is a typical phenotype of necrotizing enterocolitis. A baby who has a distended abdomen, some periumbilical erythema. This baby has been placed NPO and has had a tube placed. This baby has had a radiograph done, and here we see something very dangerous appearing. This is air in the liver. And here we also see air in the bowel wall. This is pneumatosis intestinalis. This is portal venous gas. This particular baby went to surgery because the baby continued to get worse, never had a perforation, but continued to get worse clinically. And this is what was seen at the time of surgery. You see this piece of bowel here that was highly necrotic compared to the other part of the intestine. This necrotic bowel was removed. The bowel was reanastomosed, and this baby actually did quite well. Well, at the time we wrote this article in the New England Journal of Medicine in 2011, we called this particular process classic necrotizing enterocolitis. But now in 2023, I'm beginning to think that we really do not have a truly classic form of necrotizing enterocolitis. And what was our concept at that time for this classic form of necrotizing enterocolitis? Well, here is a schema, a cartoon that shows that you may have a genetic background for the likelihood of development of necrotizing enterocolitis. And this was witnessed because very often, if you had a set of identical twins in a neonatal ICU, and one of them developed necrotizing enterocolitis, the likelihood of the other twin developing necrotizing enterocolitis was higher. However, studies have been done with genome-wide sequencing, and there have been some regions of DNA that look like they might be suspicious, but they have not been consistent. But we think that genetics may play a role. And then we have something called altered microbiota, and I'll talk about that a little bit more later. And the altered microbiota usually have a low diversity that is caused by antibiotics. And then we have this very immature gastrointestinal tract, and this immature barrier has intestinal epithelial junctions that are wide open. And with them being wide open, what happens is that microbes and other antigenic material can easily translocate through this leaky gut, and that can then cause exaggerated inflammation because there's also decreased mucus, decreased IgA, and as I mentioned, the low intercellular junction integrity and increased permeability. And this exaggerated inflammation will lead to intestinal necrosis. Well, this is the concept that we've had for the development of necrotizing enterocolitis. And here's just a continuation of this: genetics, immaturity, microbial dysbiosis. I mentioned all of these already, but where's hypoxia, ischemia, and feeding? Well, in the early days of neonatology in the late 1970s, it was thought that hypoxia, ischemia was a major cause of necrotizing enterocolitis. Our concept has changed considerably since that time. And because of that concept of hypoxia ischemia, this animal model was developed at Columbia University in the late 1970s. What are we seeing here? Well, these little baby animals, baby rats, are placed into this plastic bag. The plastic bag is closed, And that's close for about 7 to 8 minutes until these animals get blue, very dusky appearing. They start gasping. You take them out of that bag, you put them into a refrigerator, subject them to cold stress, take them out of the refrigerator, tube feed them with something very different than what they would be getting from their own mothers. And frequently, one iteration of this model is you also add endotoxin or some other very noxious material to the feeding that causes inflammation. Well, this is a highly artificial model and really does not represent very much what we see in our premature babies. This is based largely on hypoxia ischemia. But when does most hypoxia ischemia occur in these babies? Usually early on. And when does necrotizing enterocolitis develop? Well, here we see corrected gestational age in weeks at NEC diagnosis. And here is the number of NEC cases. In the babies who are born really preterm, 23, 24 weeks gestation, it takes time for those babies to have this higher incidence of NEC. So if a baby is born at 23 weeks gestation, it takes several weeks for that baby to develop NEC. And hypoxia ischemia has almost nothing to do with their development of intestinal necrosis. If a baby is born at 27, 28 weeks gestation, it doesn't take quite as long. Why does this occur? Why do we have this peak between 29 and 31 weeks corrected gestational age? Well, here are a few hypotheses that have been raised. Well, here what we're seeing at this period of time is microvascular changes in the entire body of these babies. An example is the microvascular changes that occur in the eyes. We rarely see retinopathy of prematurity prior to 30 weeks gestation because the blood vessels in the eyes and the retinas have not even developed yet. Well, very similar processes are going on in the gastrointestinal tract. And if there's maldevelopment of these microvasculature maturational events, there can be problems similar to what we are seeing in the eye. Immature barrier function, I mentioned that is a definite concern. Toll-like receptor developmental patterns. So what are toll-like receptors? Well, toll-like receptors, the one that we are most concerned about is something called toll-like receptor 4. And in the late second trimester of pregnancy, we see the highest concentration of toll-like receptor 4 in the gastrointestinal tract. Toll-like receptor 4 responds to lipopolysaccharide, which is a substance in the cell walls of certain gram-negative, highly pathogenic microorganisms. And we also see microbiota changes. We see different kinds of microbiota in those babies who subsequently develop NEC versus those who do not. And here's a study that supports this. This was a study that was published by Dr. Mohan Pami and myself in 2017 in the journal Microbiome. What we did in this study was that we took sequenced data from 8 different neonatal intensive care units, and the sequence data was obtained from stools from babies on at least a weekly basis, starting from week 24 through week 36. And we compared the microbiome of babies who were control babies versus those babies who developed necrotizing enterocolitis. The microbiome studies were done by 16S sequencing or whole genome sequencing. So what are we seeing? Here are the control babies, and you see the blue here stays about the same. This dark yellow stays about the same. And here we have this bright yellow at the bottom, which is not very highly representative, but we do see more of this bright yellow in the control babies than we see in the NEC babies. We also see this dark yellow about the same in the controls, but decreasing in the NEC babies. And here we see this blue staying about the same, but increasing in the NEC babies. So what is the blue? The blue are the proteobacteria. And in the neck babies, we see more proteobacteria. Proteobacteria are largely gram-negative microorganisms with a lot of LPS, lipopolysaccharide, in their cell wall. And remember, lipopolysaccharide stimulates toll-like receptors, which are very high in the late second trimester of pregnancy, which is a time when most of our cases of so-called NEC occur. The firmicutes are this yellow here, and these microbes decrease during this period from 24 to 36 weeks. What are the firmicutes? They are largely gram-positive microorganisms that are good guys. They tend to produce short-chain fatty acids such as acetate, propionate, and butyrate. Butyrate is the most important fuel for the colonocytes. Butyrate also maintains tight junction integrity so that you don't have a leaky gut. And here, this very bright yellow, you see more of the bright yellow in the control babies than in the neck babies. Well, what does that bright yellow represent? These are the bacteroidetes. Bacteroidetes have a certain component in their cell wall that stimulates dendritic cells to cause a change in the type of lymphocytes that we see in the subepithelium from an effector T cell to a tolerizing T cell. And with tolerizing T cells, you blunt the inflammatory response. Well, we have more of these microbes that can blunt the inflammatory response in the controls than we have in the neck babies. So you can see the types of microbes seem to correspond very nicely to the development of intestinal inflammatory responses. What are some of the things that we do that may lead to this? Well, here we see the most commonly used drugs in the neonatal intensive care unit. And at the very top are ampicillin and gentamicin. Now, please think about how many babies, premature babies, that are less than 32 weeks gestation who never get a course of ampicillin and gentamicin, or at least some antibiotics for a day or two after birth. This is very, very common. And I would say most of our preterm babies get a couple of doses of ampicillin and gentamicin those first 2 days after birth. What does this do? Well, here is the situation without antibiotics, where you see a balanced microbial community with high species diversity. You have good toll-like receptor signaling. You have increased barrier function. And here, after using antibiotics, you get rid of the balanced microbial community. You lose a lot of the commensal microbes. And so you have altered toll-like receptor signaling and immune dysregulation, which can lead to a hyperinflammatory state in the gastrointestinal tract. Now, some have said that, oh, let's only give the baby 48 hours of antibiotics after birth, and 48 hours is not going to cause any problems. Well, this is a study that evaluated the effects of ampicillin and gentamicin within 48 hours after birth, only giving 2 days of antibiotics. At the top, we see treated babies at day 4, and here at week 4, and here we see them at week 8. Here we see the controls. And one of the things that we see here is that those babies, you see this blue here in the treated babies, it's much higher than the blue in the controls. These are the proteobacteria. And we see a imbalanced microbial community in the treated babies in week 8 and in week 4. So this has a long-lasting effect. It's not just for a few days. So what could this potentially do? This is a retrospective observational study, one of 3 studies that incurred the same results. Here we see babies getting 5 to 8 days of antibiotics. Here this arrow represents what happens to these babies. So here we see the odds ratio for the development of necrotizing enterocolitis depending on number of days on antibiotics. And if the baby is on 5 to 8 days of antibiotics, that increases the odds ratio for the development of NEC by 50%. This is a study that we did at the University of Florida just a couple of years ago, and this was one of the first prospective randomized trials of giving ampicillin and gentamicin or not giving it. And here this is a pilot study, so a small study. We enrolled 98 babies, and this was a pragmatic randomized control trial because there were certain babies who we had to give antibiotics to. And this was a high-risk group. The high-risk group is one where the mothers had very high fevers prior to delivery. They may have had pus at the cervix, very high-risk babies that we could not justify not giving antibiotics. Then the rest of the babies were randomized to either get antibiotics or not get antibiotics. But what we found was that when we looked at clinical outcomes, clinically adverse outcomes, there were no differences between these babies and these babies getting antibiotics or not getting antibiotics. But when we looked at the fecal microbiota, these are the two randomized studies. This is the study with the high-risk group, this group here. But you see, even in the randomized groups, you see some separation in this principal component plot. That means that the baby's stools were different in terms of their microbiota overall. This heat map looked at different kinds of bacteria that were either elevated or decreased in the babies getting antibiotics or not getting antibiotics. And of interest is that we also, after looking at the types of microbes, we also looked at the metabolites being produced by these microbes. And what we saw was that there were certain microbes that were actually decreased by the use of antibiotics, and that related to certain metabolites being decreased. So, for example, one of the microbes was Veillonella. Veillonella was significantly decreased, and along with this decrease, we also saw a decrease in gamma-aminobutyric acid. So these bacteria produce this very important neurotransmitter. And what that implies is that loss of that very important neurotransmitter may actually have neurodevelopmental consequences. Much more work needs to be done in this area, but this was a pilot study that suggested that antibiotics may actually have some very significant effects on the metabolites in the gastrointestinal tract and the types of microbes in these babies. Now, these studies were largely associative, not causal. We did not prove any causality with these studies. And so when studies find an association between two things, that does not mean that one thing caused the other to happen. And it's important to have studies of causality rather than just associations. And there are several possible remedies for finding causality rather than association. Some of these can be very difficult. I said before that our studies in animals could be potentially helpful, but the studies in animals have not really helped us very much in studies of necrotizing enterocolitis. We can use randomized controlled trials with one main prime outcome, but these are highly expensive and usually cost millions of dollars. So, for example, if we wanted to do a randomized controlled trial in something that may decrease necrotizing enterocolitis, we'd need at least 1,500 babies to do this study correctly for a good sample size that gives us adequate power. And then finally, I want to get down to here, multi-omics and artificial intelligence. Well, how can we harness these? How can we mesh artificial intelligence with multi-omics in diagnostics and therapeutics in neonatology, especially when it comes to necrotizing enterocolitis? Well, here's a study that we did at the University of Florida and published a couple of years ago in the Journal of Pediatric Surgery. And what was done in this study, we used a technique called machine learning. And what was done was that babies who went to surgery and developed spontaneous intestinal perforation and seen at surgery versus those babies who had more of a classic form of necrotizing enterocolitis were compared in terms of their features prior to the development of these problems, okay? And this is a technique called supervised machine learning. Why is it called supervised? Well, what we wanted to do was find features that associate very highly with the development of SIP versus classic necrotizing enterocolitis before these babies even go to surgery. And so we knew what the outcome was, but then we went back and used two techniques, one called ridge logistic regression, and the other one was called random forest. And these are statistical techniques that are used in supervised machine learning to try to find features that are highly related to one disease entity or another. And here we see some of the features that were highly related. And here's the accuracy curve. And you can see the accuracy curve for both of these ridge logistic regression and random forest studies was very high. This is considered to be a highly accurate study. And using some of these features, we should be able to differentiate spontaneous intestinal perforation from true intestinal necrosis before they occur. This could be very helpful for surgeons. What about unsupervised machine learning? Before I talked about supervised machine learning. So here we have these different kinds of fruits, apples, strawberries, and peaches. And if we take these and put them into a basket and shake up the basket, we'd like to be able to determine or categorize all of these different fruits. And unsupervised machine learning is something that can categorize or cluster different entities. So you take this raw data and you put them into a unsupervised machine learning clustering algorithm, and the output is going to be different clusters, discrete clusters such as apples, strawberries, peaches. Okay. We did this with babies who had intestinal injuries. We had 200 babies who had different forms of intestinal injury or dysfunction. And on the x-axis, these are just identifiers that we used for these babies. And here are some of the outcome measures or some of the features that were put into these algorithms to do unsupervised machine learning. This is what's called a heat map. We cannot just look at this heat map with our own eyes and discern what the different clusters are, but a computer can do this. And the computer algorithm found 5 different clusters of intestinal problems. You can see these clusters here. We just put some names onto these to give them some description, but we are not calling them necrotizing enterocolitis or spontaneous intestinal perforation. We are not yet giving them a name, okay? This is technique that we are using to sort of start all over again and find certain types of clusters of intestinal injury in our premature babies. So what do we do after we do this clustering? Well, one of the things that we can do within each one of these clusters is to use a technique called multi-omics. Multi-omics means we are not just looking at genome, microbiome, metabolome, proteome. We are trying to put them all together and integrate them. Why is this important? Well, let me give you a nice analogy here that I really like to use. This is the story of the 6 blind men of Hindustan. Okay, these guys are blind, and they're all asked to feel this structure. And one blind man goes to the side and says, this feels like a wall. The other blind man goes to the front and says, this feels like a spear. The other one goes to the back and says, this feels like a rope. all the 6 blind men get back together after doing their examination of this structure. They argue, and they're all very adamant at what they felt. But because they're so dogmatic and so adamant about what they felt, they never were able to integrate their ideas. Well, the same thing happens when we only use microbiome. Remember, I was giving you microbiome information before. That was not causal, that was associative. If we use proteome information or genomic information, that is associative. But if we put them together into a nice picture, systems biology mechanism picture, that will give us much better idea of what is actually going on in terms of causality. And so this is where we should be going in the future, using AI to cluster these different forms of intestinal injury. And then once we have these different forms clustered, then we go back and do this multi-omic technology to try to determine what the actual mechanism is. And once we determine the actual mechanism, we can look at these systems biology approaches and then find certain nodes, certain areas, certain biomarkers that we can use very early in the course of these babies and see if these, and try to utilize these biomarkers to utilize preventative strategies for each one of these different newly found disease entities that we are now calling necrotizing enterocolitis. But hopefully in the future, we will stop even using the term necrotizing enterocolitis because it is so diffuse and unhelpful. So strategy for the future. Let's begin to make believe that the term necrotizing enterocolitis never existed. We go back to the late 1960s, early 1970s, and retrospectively evaluate a large data set of preterm infants with various forms of feeding intolerance, putative intestinal problems, defined intestinal problems, and cluster these phenotypes. And we do that by using 2023 artificial intelligence. We develop biomarkers that better differentiate these more discrete clusters, and we study the pathophysiology of each individual cluster using integrated multiomics to develop preventative and therapeutic measures. We still have a ways to go, and I think that we're thinking here 3 to 5 years in the future. But this is hopefully where we will be going, and totally having a different concept of intestinal problems in our preterm infants. Thank you for your attention.
Thank you, Dr. Joseph, for your fascinating, really, truly fascinating lecture. It has put us really in the future. And this is the first time I see how we can integrate AI in the field of neonatology. I don't know if there are any questions in the chat box. I can't find any questions in the chat box, but I wanted to ask you a question. What about the role of ultrasound in diagnosing and necrotizing enterocolitis?
Well, we've got one of the world's experts in abdominal ultrasound. Yasser is here, and
Okay.
so I think that, and Yasser and I have talked about this on many, many occasions, and I think that, and I maybe Yasser can comment on this. I think we should be able to say that a bowel is not a well-appearing bowel, and not necessarily call it necrotizing enterocolitis. You can see something on ultrasound that is, where the bowel is not moving, where the bowel is thickened, where you may have some pneumatosis, find the abnormalities and give some kind of an idea of, maybe grade some level of illness to that. But I don't think you need to call it necrotizing enterocolitis.
Absolutely. Joe, I can just say, add a quick comment. Thank you first for the wonderful presentation. I listened to this presentation probably many times now, and each time I enjoyed the same as a previous time. So thank you very much. Exactly as you said, ultrasound does not diagnose a specific disease. It diagnoses abnormalities or certain types of injuries that might fit with different diseases. And we were able to differentiate food protein-induced enterocolitis with what's called now in our unit gut injury. We are not using NEC in our unit anymore. We are using gut injury. And the gut injury can be due to different reasons. Can be prematurity-related gut injury, can be due to ischemia, which could be localized ischemia and like small part of the bowel, which might lead to perforation that might be induced sometimes by medications like steroids or endomycin, might be induced by just infant IUGR exposed to ischemia for some time. Gut injury might be secondary to ischemia related to hypoxemia with congenital heart disease. In rare cases might be associated with HIE. So we have two different types of gut injuries. And unfortunately, most of the units around the world, they are still mixing up everything all together. So the ultrasound has a beauty to differentiate different types of markers that might exist in different pathophysiologic related issues, but definitely does not diagnose NEC, which I believe does not exist as well-defined disease. I agree with you 100%, Joe.
Thank you.
Okay, Dr. Joe, some questions have come up. Someone is asking about the use of probiotics in preventing necrotizing enterocolitis.
Sure. Well, that's sort of a long story, but I'll try to shorten it here. Back in 2010, this meta-analysis came out in the journal Pediatrics, and it was highly suggestive that these probiotics may be helpful in the prevention of necrotizing enterocolitis. Well, if you look at that meta-analysis very closely, it was from 11 different neonatal intensive care units, 10 different probiotics were used. If you're using 10 different probiotics and putting it into a meta-analysis, I think that there's something wrong with that. We're beginning to learn more and more that these probiotic preparations that are being used today are not quality products. They are food products. They are not pharmaceutical grade. They are not approved by regulatory agencies, such as the Food and Drug Administration, the European regulatory agencies. And there's some studies actually showing that if you look at the probiotic preparation itself, frequently, there was one study that looked at 15 different probiotic preparations. Only one of them actually had what it was advertised as being. So I'm very skeptical, and there's only one good prospective randomized controlled trial that was done in UK with 1,300 babies adequately powered, and it showed no difference in the development of necrotizing enterocolitis or sepsis. So I think that we need to have a better idea of the actual definition of these different diseases that we are calling necrotizing enterocolitis, and then see if we can develop therapeutic measures for each one of those separately once we have a better idea of the pathophysiology.
There's another question. What is your advice regarding initial use of antibiotics, especially when we suspect NEC? Will we keep the PPN and PO and start antibiotics? Is it like a vicious circle?
I think that there are many babies that we are suspicious of having some intestinal problem, and because we are so afraid of the baby progressing onward toward getting, more of a necrotic process, that we treat so many babies with antibiotics, with NPO, with tubes for these long periods of time, that we are actually causing more damage than we are causing good. So we need to have a much better understanding of what is actually going on with these babies. We are becoming, I think, at least in our unit, we're trying to be more skeptical. And, like Yasser is doing something using ultrasound. And I think that that can be very helpful, but not everybody has that kind of skill to be able to use ultrasound. And I'm hoping that Yasser can develop something that others can look at very simply. People without that same level of skill can look at very simply to help us diagnose a level of intestinal injury, so that we can either not give antibiotics or give antibiotics, and not put these babies NPO for these prolonged periods of time.
Another question, can a triad of thrombocytopenia, hyponatremia, and high CRP help for the diagnosis of neonatal NEC?
Those are very non-specific biomarkers. If you see a baby with a very distended abdomen and low sodium, high CRP, I think that I'd be very suspicious of some intestinal necrotic process starting. So yes, I think that they can be helpful, but they're not specific.
Mm-hmm. Yes. The last question, can dopamine be of any value to increase the splanchnic blood flow?
Many years ago, we thought that very low dose dopamine might be able to do that. I'm skeptical. I think that I would not do that anymore. One of the best things that actually increase splanchnic blood flow is putting food into the gastrointestinal tract. So rather than using dopamine, I think we need to use the gastrointestinal tract and feed it.
Mm-hmm. Yes. Thank you, Dr. Joseph. It's a magnificent lecture, really. Yeah, Dr. Yasser, if you want to close the lecture, the session.
Thank you very much indeed, Joe. I know that you are on a vacation in Sicily, and thank you very much for your time and for your excellent presentation and for surviving all these hours. I know that we are late, but thank you very much indeed. And thank you very much for all the speakers and moderators. Thank you very much, my dear friend, Dr. Yasser Said. Hoping next year it could be the same, inshallah. Joe, whatever I say, you did a lot. Thank you very much. Your presentation was excellent. Each time I hear you, different way. I heard NEC maybe 15 years ago or more than 10 years ago in Cairo, in the Hippocrates, if you remember.
Yes, I do.
Completely different. It's the same title, but it's different way and different approach. Unfortunately, up till now, I am using dopamine to increase blood flow because we cannot put food into the gut in necrotizing enterocolitis children, especially we don't have the tools to definitely diagnose it.
So I hope you didn't misunderstand me. If you have already made the diagnosis, I would not put food into the gut if you've made that diagnosis, okay? But food in the gut can actually help prevent gut injury, okay?
Okay, thank you very much.
Okay.
Yeah, typically with my maybe conversation with a lot of colleagues and all over the world, they mistreat or they misdiagnose a lot of cases, and they assume they have neck or gut injury, And the real situation is actually normal, or maybe food protein-induced enterocolitis in a lot of situations. And instead of choosing the right food to give, they keep MPO, which I think if we work on this category, we avoid a lot of gut injury that might happen because of antibiotics and keeping the infants without feeding for a long time. So I think that probably the category that you meant, Joe. A lot of cases, the physician, they kept MPO, but without a good rationale.
Yeah. Yeah. Yes, may you conclude?
Yeah, thank you very much, everyone. I really enjoyed everything from everyone, the moderation, the questions. I learned a lot today. So thank you very much. And hopefully we'll see you again next year. And probably we'll meet physically in Egypt at some point in the future.
Inshallah, hoping so. Bismillah. Thank you very much, all dear colleagues and friends, and either moderators, speakers, or those who are following us. We started early in the morning, Egyptian time, 9 o'clock, and now it is in Egypt 12:30. So it's approximately 15 hours. So in Friday only, Saturday and Thursday, less anyway. Thank you very much indeed. Hoping we meet again next year, 2024. Thank you. Thank you.
Inshallah.
Thank you.
Thank you.
Thank you very much. Thank you all. Good night.
Thank you.
Thank you very much indeed.